discuss the approach to shoulder pain today. So as we all know, shoulder is a very complex joint. It's comprised of 4 different small joints. And it's very important to know where the pain generator is from to really reach an accurate diagnosis. So broadly, there are 4 pillars when we look at any shoulder problem. The 4 pillars, the first pillar is a good, accurate clinical history. The second is the conventional examination sequence that we follow, like look, feel and move. The third is the special test, and the fourth pillar is radiological investigations. So the method that usually should be followed is after a good history and a conventional examination, we should have a working diagnosis. And we have a working diagnosis, we should apply some special tests to that particular diagnosis for that particular thing. Ask for the pertinent investigations to reach a diagnosis. We should be able to classify and formulate a good treatment plan. This is a very important slide. This is about the reliability of the diagnosis. So when we have a precise diagnosis, when all the 4 pillars align themselves, so if you find that all the 4 pillars are aligning themselves, we reach a precise diagnosis. If none of them are overlapping, then it's a very unlikely diagnosis. And when there is some overlap, then it requires to be further evaluated, sometimes in the form of an invasive investigation like a diagnostic arthroscopy. Now let's go on to the first pillar, and that is the history. Now, shoulder problems usually follow a very pattern. They follow a pattern. We need to recognize the pattern. Now, shoulder pain in a child is usually mostly traumatic in origin, and non-traumatic origin in a child should basically point us towards some kind of a primary tumor. In the young age also, most of the pathologies are traumatic in origin, and most of them are related to instability. In the middle age, we start getting rotator cuff problems like tendinopathy. And in the elderly, we have rotator cuff tears and arthropathy. So if I get a child, I'm never going to think about a rotator cuff problem, or a young adolescent never going to think of a rotator cuff problem. It's mostly going to be something related to either trauma or instability. Now, profession also tells us about what kind of problems usually the patient would be coming with. What is he here for? So usually teachers and mechanics would usually have rotator cuff problems. People who are doing computer jobs or a desk job usually have postural problems and end up with impingement, while athletes usually would complain of labral tears or impingement, posterior impingement. So what are the 4 symptoms? Mostly the symptoms that usually the shoulder patient would come with is pain, stiffness, weakness, and instability, like a feeling of insecurity or an inability to throw. Now we have to see much in detail about each symptom. Pain, how does it start? Now most of the pains are usually heralded by some kind of an injury, but it has to be commensurate with the pain temporally also and in magnitude also. And also we require to ascertain whether shoulder is the source of the pain, whether it's arising from some other, it's from the cervical spine or from either the thoracic outlet. So the location of the pain, sometimes the pain arising from the shoulder is not localized to the shoulder. They would sometimes point towards the insertion of the deltoid. Because of the deltoid overload, we may have symptoms which is lower down in the arm. Usually, classically, we have the palm sign, in which you see this figure, in which the patient points towards the arm, which usually will show rotator cuff problems. And finger sign like this would usually, if it shows the finger, it's usually most of our AC joint problem. Sometimes we have to ask for whether it is associated with some kind of neck pain or medial scapular tendon spots. Again, what is more important is what is the character of the pain. Usually the pain arising from the shoulder will not travel below the elbow. It will be worse at night. Rest pain is usually a red flag, should point towards some kind of infective or inflammatory or a neoplastic pathology, while jarring pain on slight movement is usually very classical of sometimes adhesive capsulitis. Apart from the pain, does the shoulder feel weak? Does the shoulder feel unstable? Does it feel stiff? If the shoulder feels weak, again we want to know what is the age of the patient, whether it is traumatic in origin, whether it is non-traumatic, what is the position. Usually position in abduction and external rotation, if it feels weak, is more of anterior instability. While in adduction, if it feels, then usually it's more of a posterior instability. Sometimes there may be a neurological cause associated with the weakness. So once we are finished with a good history taking, then we go on to inspection. There are a few things which we can make out on the inspection. One is wasting. There is an obvious wasting of the supraspinatus or the infraspinatus. There's sometimes a Popeye sign in a biceps tendon rupture. It's also a good. The AC joint contour can be made out in an inspection. Scapular dyskinesia, which is a very common thing described by Kibler, is a thing which can be found on inspection. A pectoralis major tears. These are the things which we can find out on inspection. And when we go on to palpation, we usually first thing that we should look for is whether there is any ligamentous laxity. There is a Baton score. So anything more than 5 on a score of 9 is pathognomic of a ligamentous laxity. Then we go on to soft tissue palpation. We can palpate the biceps tendon. Usually most of the glenohumeral joint cannot be palpated, but we can palpate soft tissue. We can palpate the biceps tendon in this. And then we go on to the bony palpation where we palpate the AC joint and the clavicle. The next thing that we have to see is the movements. So always the active movements are checked first. The 3 movements that are checked are forward elevation. We should document how much is the forward elevation compared to the other side. External rotation with the arm adducted in 90 degree of flexion. And internal rotation is usually reference to the vertebral level. Then after the active movements are checked, we should check for the passive movements and we should check for the total arc. Sometimes the arc is changed in a condition called as a GERD, in glenohumeral internal rotation deficit, mostly seen in throwers. So whether it's the same arc as the opposite side, sometimes the entire arc is maintained, but it's shifted in some kind of in a deficit, internal rotation deficit. So once we have done the history and the conventional examination, then we go on to the special tests. Now there are a few things that I would like to mention. Now, as an examiner, we should stick. There are a myriad of tests that are described, so we usually stick to those which we are comfortable with, and in which we are not able to give more pain to the patient, and keep on doing it. So by practicing those special tests only, we stick to only a few tests. So these are the tests which we usually stick to. They have a good specificity and a sensitivity. So I have classified them into the test for impingement, test for rotator cuff pathology, test for biceps, and test for instability. So what are the tests for impingement? So this is what we call as a knees impingement sign, in which the shoulder is forward elevated, and in the terminal forward elevation, pain is elicited. There is something called as a knees test, in which local anesthetic is infiltrated in the subacromial space. And if the range, either reduction or abolition of pain, then that is pathognomic of a knees. It's pathognomic as an impingement sign, and that's called a knee test. Then there's something called as a Hawkins-Kennedy test, in which the shoulder is forward elevated to 90 degrees, and it is externally rotated and neutral, and then it is internally rotated to 90 degrees, and if pain is elicited in an internal rotation, that is pathognomic of a impingement sign. Then we go on to the tests for rotator cuff problems. So the test that is important for to test the integrity, the strength testing of the supraspinatus, is the Job's empty can test. In the empty can test, usually the arm is internal rotated. Sometimes it causes pain. So there has been a test which has been called as a full can test also, in which the arm is external rotated, and it is less painful because there is less impingement on external rotation. And study by Etoy says that both of them are sensitive and specific, but for strength testing, full can test is more better because the pain generator goes into the external rotation. Now to test for the infraspinatus, one has to test for external rotation against resistance. So again the limb is adducted and the elbow is flexed to 90 degrees, and we check for the resistance against external rotation force. So weakness usually will tell you about the infraspinal strength. Then there are some lag signs. So the figure on the right is usually a lag sign. So usually we hold the limb to the trunk and then external rotate and then leave it. So if it recoils for 10 degrees back, then usually it's infraspinatus that is weak. If it recoils more than 40 degrees, usually the infraspinatus and the teres minor both are weak. And the figure on the left is what we call as the Hornblower's test, in which the patient is asked to abduct and keep the hand in external rotation. Ability to maintain this particular position when it falls down is the Hornblower's test. Now the test for the subscapularis, there are 3 tests for subscapularis. One is the lift-off test, in which this has been described by Christian Gerber from Switzerland. So in which the palm of the hand is kept on the sacrum, and he's asked to lift the palm from the sacrum. If he's able to lift it away from the sacrum, that means the subscapularis is working. Then there's a belly press or the Napoleon test, in which the hands are kept on the belly and they are asked to press the belly backwards. So in case of a subscapularis weakness, the patient is unable to maintain the elbow in front of the trunk and the elbow falls back. Now the test for the third test usually for subscapularis is what we call as a bear hug test, in which the patient is made to touch the other shoulder and the examiner tries to lift up the shoulder from the particular shoulder, and a good amount of resistance will indicate that the subscapularis is intact. So the test for biceps tendon pathology, there are 2 tests. Now the first one is Yergason test, in which the supination is resisted and the biceps tendon is felt over there. So pain at the site of the biceps tendon is a positive Yergason's test. And in speed test, the elbow is held extended and the limb is asked to forward, or you can just keep it forward, the shoulders kept forward flex and the elbow is extended, and a downward pressure is given, and the patient is asked to maintain that particular position. Pain at the site of the biceps tendon is a positive speed test. Now there are a few tests for labral pathology. Now the first one of them is the crank test. Now crank test is not very specific and sensitive, but it is very analogous to the McMurray's test that we perform in the knee joint, in which the shoulder is elevated, the elbow is flexed 90 degrees, a axial force is given, and then external and internal rotation force is given to the elbow with the forearm as a lever arm. And if there is a clunk felt or some kind of a click felt, it is usually indicative of a labral pathology. There is something called the O'Brien's test, in which again the shoulder is forward elevated, it is adducted and internal rotated. The patient is asked to maintain this particular position in internal rotation, then a downward force is given. If there is pain which is alleviated when the forearm gets supinated, then usually when the forearm is external, the shoulder is external rotated, then that is pathognomic of a labral pathology. Not a very specific test. Now let us see some tests for instability. So the most common test that is done for instability is an apprehension test, and this kind of a test is usually with the arm in abduction and external rotation. If there is apprehension for the forward dislocation of the elbow, it will tell you about an anterior instability. And a relocation test, in which the patient is lying down, again an apprehension test is performed in a lying down position, and then when the posterior force is given in the arm, and the apprehension should be relieved by this particular test, and that is a positive relocation test. Sometimes when we leave this particular the posterior, then we get something that the apprehension comes back, and that is what we call as a surprise test to see the apprehension again. Sulcus sign will be positive, in which a downward force is given, and we can see a sulcus at the subacromial space between the humeral head and the lower part of the acromion, telling you about inferior instability. And the last test that we usually perform is what we call as a jerk test, and this is usually for posterior impingement and posterior labral pathologies, in which the arm is forward elevated, a longitudinal axial force is given along the arm, and then the arm is abducted. If there is a sudden clunk or a reduction felt, then usually that is pathognomic of a posterior. After all these tests, to corroborate, there are a few things. The most common an orthopedic surgeon would ask for is for an X-ray. X-rays will show some things can be seen on X-ray. The calcific tendinitis can be seen on X-ray. Rotator cuff arthropathy can be made out on an X-ray, and AC joint arthritis can be seen with a specific Zanka view, in which an AP view there is a cephalic tilt of 10 to 15 degrees. USG is also a very good modality for rotator cuff problems. It is accurate, quick, and dynamic. Disadvantage is that it is operator dependent. It is less accurate than an MRI. It cannot assess pathologies like interstitial tears. And if the patient has limited in ROM, then the dynamic thing cannot be tested. For the long head of the biceps, a good test. Whole muscle and tendon can be assessed. I'll just take 2 more minutes. For calcific tendinitis, it is the USG is the most sensitive modality for calcific tendinitis and can help you in guide you in doing a barbotage. In labral pathology and instability, USG is of no use. It is useless in labral pathology. Fluid collections again is useful. I'll just hurry up. MRI again can diagnose with more accuracy the soft tissue problems like a rotator cuff tear or a Bankart lesion. It can also help us grade any atrophy in the muscles. And the last muscle, CT scan is the go-to in trauma, and sometimes in bipolar instability problems, CT scan can help us know whether it is an off-track or on-track lesion.